appropriate number of regular staff. We are moving from a structure that was around 300 people to a structure that can now accommodate 900 people. And for that, this is good news for us. It's giving us the opportunity to fulfill our mandate, to build a stronger, more efficient organization capable of tackling future health challenges across the continent. This is the way for me and the opportunity for me to call upon all countries, all African talents, all African experts to start to look our website. We want to hire around 100 skilled and talented Africans by December 2023. And it means all positions will be advertised. We need Africa CDC to represent the diversity of Africa in terms of gender, in terms of geography, in terms of language. Feel free to go because our applications are advertised in all languages. As Director General for Africa CDC, while I'm talking about this 3 success from Nairobi, I can't skip talking about what we are doing on daily basis. It means supporting our member state to manage a number of outbreaks that we have. For your information, every week we have at least 2 public health threats, including outbreaks or major diseases in our continent affecting our member state. Actually, we are following some high-risk event and moderate event in addition to others. Some of these high-risk events are like cholera. Cholera is affecting 15 member states. It means almost 30% of countries, with around 2,600 deaths till date. This is huge. We are also following measles. Measles affecting 22 member states with almost around 2,000 deaths. We are following COVID-19. Many people, they think that COVID is the past. It's not the past. We still have COVID. As a reminder, we have around 260,000 deaths due to COVID. We are following diphtheria in some countries like Nigeria with a number of deaths. We are also following monkeypox in 5 member states with already around 2,600 deaths. And of course, we are following polio that is affecting 10 member states. Every day, we have colleagues running, going to support countries. Just for cholera, we have to affect 1,300 experts and community health workers to support Malawi and 2 other countries to tackle this disease. It means Africa CDC is really safeguarding the public health in Africa. And we hope that with all tools that we have now, with our governance structures in place, with our structure of more than 900 people, plus the 155 regular staff that we got from the Executive Council, with our budget that was approved, and with the strategic plan that was validated by the Executive Council, we are well positioned to deliver, and we hope that together with our member states, with our partners, we'll do that great job that can help us to transform the agenda of health in Africa. Thank you.
Thank you very much, Dr. Jean Kaseya. Colleagues, there you have it, a complete breakdown of some of the processes that have been going on to ensure that Africa CDC has been fully capacitated, and also the rundown of some of the challenges, the public health challenges that we are facing on the continent. It is now time for us to get into our question and answer section. So from the room, we will have a show of hands so that we know who has a question or a comment to make. And online, please utilize the chat section. We are not taking any live calls, but please do send your questions in through the Q&A or the chat section. Okay, somebody just wrote to say, I cannot hear the English version. All right, this is something for our technical team to attend to. If there is any fault there that might be going on, please attend to that. But for your questions, please utilize the question and answer section and not the live broadcast. All right, so from the room, let's start. Do we have anyone who has a question that they want to put forward? Kennedy, Pana Press.
Thank you. My name is Kennedy Abao. I work for Pan African News Agency. My question is, you mentioned the Africa healthcare system. Could you explain to us what you mean by that? Just try to break it down for us so that you understand what you mean by the healthcare system and why you need to invest in it. And also on the other issue is, I remember some countries did invest money in keeping the CDC to come to operation. But what are the African countries doing? What is their input in the CDC? How much of the ownership is African? Thank you.
Thank you. Over to you, DG.
Thank you very much. I think, Kennedy, these are two important questions. And when we are talking about Africa healthcare system, you know, I have to say to colleagues that when I started my public health 25 years ago, we're talking about primary health care. Primary health care, you know, we had some entry point. Each country could use each one of the entry points to build the system. Mostly, many countries, they were focusing on one. Maybe it could be vaccination, maybe it could be nutrition. But we saw that with this approach, we are not really building the system. Then we moved from primary health care to embrace the concept of health system strengthening. The health system strengthening tools, okay, let us sit, plan according to the system and develop an integrated plan that can help us to really to make sure that we are pushing the agenda of the system, not of one intervention. And this health system strengthening came with some pillars, what we call the key 5 pillars of the health system strengthening, like human resources, like coordination, like financing, like supply chain management, like monitoring and evaluation, and others. You can see others, they will also add like community health interventions. These key pillars were almost cross-cutting pillars for interventions, how to strengthen that to make sure that we are moving with the agenda of health in Africa. Then we saw that there was something that was missing. It was the appropriate funding of the system, domestic funding mostly. This is why we came with the concept of universal health coverage. If you see the universal health coverage, it's mostly the health system strengthening based on the primary health care plus the financing component. We did very well. Some countries, they started to achieve some global agenda. I don't want to name countries, but I'll congratulate these countries. And when COVID came, we understood quickly that there was a missing component. This missing component is the local manufacturing. Let me share with you, colleagues, that we have only 1% of our vaccines we are using in Africa produced in Africa. It means when we got COVID, all of us were affected. We didn't have appropriate vaccines and medicines. This is why we moved from universal coverage without saying we are stopping that. We are not stopping universal health coverage. We moved from universal coverage to the pandemic preparedness prevention response. If you see the pandemic preparedness prevention response, the way we are approaching that, it's really the primary health care the health system strengthening, the universal health coverage, plus local manufacturing. The strategic plan that we are sharing with you today, it's really based on the pandemic preparedness, prevention, and response. Why? Because I had to share it for our Minister of Health, I have to share it for Minister of Foreign Affairs, I have to share it with Head of State. I want communities to know in the next 5 to 7 years, we'll have another pandemic. This pandemic can kill more than COVID killed. This pandemic can destroy our economy more than COVID destroyed our economy. It means when we are talking about the concept of African healthcare system, it's really to see how we are approaching the pandemic preparedness response based on all pillars that I have to explain to you today. Your second question about investment in from African countries. Yes, currently our budget is mostly around 10% from African countries, 90% from external partners. But we need to change this figure. And we are involving our head of state. We are involving our Minister of Health and Foreign Affairs and Finance. We need Africa to become serious with the agenda of health. We need Africa to invest on public health. Our public health security is first our priority. It's not the priority of external partners. While we are building this agenda, we are encouraging also partners to start to support our countries based on the strategic plan. It means we believe that there is a win-win. Yes, in the past we didn't have this kind of funding from our member state. We have to recognize that we went from like 2-3% now to 10%. It's a major jump if we consider the current financial situation of our African countries, but we have still way to move forward. We have still room to improve. Thank you.
Thank you very much, Doctor. I will hand over to my colleague, Dr. Benjamin, to ask the next question, which is coming on Zoom.
Merci beaucoup, Win. La question d'un anonyme, à quel niveau l'expansion de l'appui d'Africa CDC se déplorera? Au niveau national, au niveau infranational, ainsi comment s'articulera le cadre de redevabilité inhérent?
Over to you, Doctor.
Et cette question est à multiples facettes. Quand on dit à quel niveau l'extension d'Africa CDC se fera, on parlera de la structure.
Sorry, DG. Can we get interpretation equipment for the colleagues in the room?
Okay.
I have two here in case somebody wants one.
But I know most of them are fluent in French. It's okay.
Just in case.
Ok. Donc, je disais que cette question a deux volets. Un volet sur la structure Africa CDC, un volet sur nos opérations. En ce qui concerne la structure Africa CDC, nous avons notre quartier général à Addis Abeba et je voudrais inviter les collègues et les amis qui nous suivent de mettre sur Google New Building Africa CDC, de voir ces nouveaux bâtiments qui est notre siège, un bâtiment de 17 étages divisé en deux, avec un laboratoire de un haut niveau et avec des infrastructures à la pointe. Nous avons par exemple un des plus grands centres d'opération d'urgence au monde, où nous suivons toutes les épidémies au monde. Donc, nous allons commencer à organiser beaucoup de réunions sur la santé à Addis Abeba pour que nous puissions profiter de cette infrastructure. Donc, je disais, nous avons notre siège à Addis, nous avons des démembrements au niveau régional, au niveau des 5 régions, Centrale, Afrique, centrale, sud, est, ouest et nord. Et nous avons ce qu'on appelle des Regional Coordination Centers en anglais, les centres de coordination régionale en français, où l'action d'Africa CDC se déploie au niveau régional. Et au niveau des pays, nous avons ce qu'on appelle les points focaux, et nous sommes en train de promouvoir de plus en plus comment réorganiser nos bureaux au niveau des pays. Ça, c'est au niveau de la structure. Maintenant, au niveau des interventions, Africa CDC n'est pas un partenaire de mise en œuvre qui va vacciner les enfants sur terrain ou qui va donner la vitamine A. Non. Notre rôle est plus stratégique. Notre rôle est plus comment s'assurer l'harmonisation des stratégies et des politiques dans les pays africains, comment arriver à mobiliser des ressources à la fois dans nos pays et externes pour appuyer la réponse aux maladies et aux épidémies dans nos pays. Troisièmement, comment s'assurer que nous avons des partenaires solides qui mettent en œuvre en collaboration avec les directives et les orientations d'Africa CDC, et aussi comment on renforce les capacités de nos organisations nationales et locales pour assurer le bien-être de nos populations. Ça, ce sont des rôles majeurs d'Africa CDC. C'est pour cela que nous sommes l'organisation de santé publique en Afrique. Et c'est ça le rôle que nos chefs d'État nous ont donné.
Merci. Let's come back to the room and have an indication if we have anyone who has a question to ask. Do we have any questions from the room before we go back online? Yes, sir.
Yes, apologies.
Just take the microphone.
Awesome. Hi, my name is Sam Kamau. I'm from Africa Forward. It sounds like we are aiming, or the key goal here is to strengthen our health systems, and I am asking from a technology perspective, or for the tools that we have, what are the challenges or opportunities in being able to use technology to actually strengthen our health systems and possibly share data that helps with localized research, such that we're making our own decisions now that the funding part seems to have been clarified.
Director General.
Thank you. Because the question is well crafted in English, I will answer in English. Look, when I described the pillars of our strategic plan, I also talked about enablers. One of the key enablers is the digital program and innovation. You are right, my brother. We will never achieve the agenda of public health in Africa without taking into consideration the technology and digital approach. Currently, I was discussing with a minister in Madrid 1 month ago, an African minister of health. He told me that he got so many partners coming to him and providing information about the digital program. He was just saying yes. He was thinking that he will move from a paper-based program to a digital program. At the end, this minister got 11 different digital platforms without interoperability, some of them piloting in one region, others piloting a specific program, others again piloting interventions. And then this minister was lost. He was asking me, Director General, what can you do to support us? Well, then we said, okay, we stop everything now. What we'll do, we'll organize a digital health summit. I want to thank the president of Benin and the president of other countries who want to host this summit. This digital health summit will help Africa City to bring all partners who are working on the digital program in Africa. We'll give them our vision, because we have a vision for the digital program in Africa. Then we'll ask them, based on this vision, how they can contribute. We want to have a digital program that can be implemented in all 15 countries with interoperability that can help the exchange of information and data. I want, as Director General, to see that if in Kenya they have a strong digital program that can help them to capture information for any outbreak, a Minister of Health in Ethiopia can have access to this information and to see how to prepare the country for the same outbreak. You see, this is our job, this is our role, to harmonize everything. And we are working together with WHO, we'll work together with UNICEF, we'll work together with all other partners with PATH, that is leading innovation in many countries, but we have also private sector. It means we'll bring all of them together during this health summit and we'll decide now the way to move forward. Definitely, I agree with you, we have to use the opportunity of the technology for that.
Thank you very much. I will hand over to Benjamin for the next question.
Thank you, Win. The next question is from Dr. Augustin Milabayo, et la question est posée en français. Que prévoit Africa CDC dans le cadre de renforcement du système de santé? Qu'est-ce qui est prévu dans le cadre de la réforme sur le financement dans ce secteur? Africa CDC prévoit-elle travailler directement avec les ministères de la Santé et le gouvernement dans le cadre de renforcement des capacités ou elle va passer par les organisations de la société civile, ONG, Système des Nations Unies, etc. Merci DG, à vous.
Merci beaucoup. Rapidement, c'est 3 questions en une. Hein? Je vais répondre en français pour notre collègue Dr. Augustin. Qui prévoit Africa CDC dans le cadre du renforcement du système de santé? Effectivement, ça c'est le premier pilier de notre plan stratégique. On veut avoir un système de santé solide, intégré, renforcé. Là-dedans, quand nous parlons du renforcement du système de santé, j'en ai déjà parlé, j'ai parlé de tous les piliers du système de santé qu'Africa CDC va supporter. Et en plus de ces piliers-là, nous avons quelque chose qui est extrêmement important, c'est le financement. Pour renforcer ces piliers et avoir le financement, nous allons travailler avec les pays membres, nous allons travailler avec les partenaires, les donateurs, comme on les appelle généralement, même si je n'aime pas beaucoup cette expression. Donc moi je les appelle les partenaires extérieurs. Nous allons travailler avec les partenaires locaux pour voir comment ensemble, ainsi que les secteurs privés, comment ensemble nous pouvons arriver à la réforme des systèmes de financement de nos pays. Ce que je dis, je le résume en leadership et responsabilité de nos pays par rapport à leur programme de santé. Nous ne pouvons pas accepter de voir un pays qui ne met pas plus de 5 ou 10% de son financement par rapport à son système de santé. Ce n'est pas acceptable. On sait que les pays ont des difficultés, mais on peut faire mieux. Africa CDC va organiser, et je remercie le président Ouattara pour accepter d'abriter dans les prochains jours un sommet sur le financement de la santé en Afrique. Et ce sommet que nous allons faire ensemble avec nos collègues de NEPAD, avec les collègues de la Commission de l'Union africaine, avec aussi d'autres partenaires, pour que nous puissions donner notre vision du financement du secteur de la santé en Afrique. C'est quoi cette vision? Nous nous disons que nous devons avoir ce qu'on appelle en anglais investment case. Nous devons commencer à définir les priorités des pays. Qu'est-ce que vous voulez avoir comme résultat dans les 10 prochaines années en termes de mortalité et de lutte contre les maladies? Combien ça coûte? Dès que nous définissons ces priorités, cette vision et les activités et le coût, nous disons par exemple que ça coûte 10 milliards à raison de 1 milliard par année. Nous demandons au pays combien vous donnez à la première année et montrez-nous comment vous augmentez votre budget graduellement jusque dans les 10 ans. Et c'est là où Africa CDC, dans notre rôle en anglais on appelle ça convening power, notre rôle qui met tous les partenaires ensemble. Nous allons amener tous les partenaires, Global Fund, Gavi, l'OMS, l'UNICEF, UNAIDS, all of them, on les met ensemble autour du pays, on dit, voici le plan du pays, ils ont besoin de 1 milliard, mais compte tenu de la situation du pays, ils commencent par 150 millions ou 200 millions, comment nous couvrons les gaps? Et nous avons des mécanismes maintenant tous les 6 mois de faire le monitoring, à la fois programmatique et financier, et nous suivons chaque fois comment les déboursements se font au niveau du ministère des Finances, comment ces budgets augmentent progressivement. L'objectif, c'est quoi? Avec ce plan de 10 ans, nous pouvons voir que le pays commence, le pays le moins qui participera sera au moins entre 50 et 60%, ce qui sera déjà un grand succès en Afrique. Merci.
Thank you very much. Let's come back to the room to see if anyone has a question. Yes, please.
My name is Pasil Telewa from Standard Group, and I'd like to know from the DG's desk, because I understand the Africa CDC last year, 2 years ago, 2021, signed a partnership, to ensure that there is more vaccine production across Africa. However, this was a partnership that didn't have many of African states. As we speak right now, I guess a few African countries, the likes of Egypt, Senegal, Morocco, and South Africa, and one more I've forgotten, I think, who are in a space that they can manufacture vaccines. What is it that you think has been ailing us? Because from where you sit, I know you understand what problems we are facing. And as you talk about another COVID-19 perhaps coming up, it may not come up as COVID-19 perhaps. It could come up as a different illness or ailment. How do you make sure that our population within member states is not again affected? Thank you.
Over to you, DG.
Thank you very much, Pasil. This issue of local manufacturing of vaccines, but not only vaccines, therapeutics, diagnostics, is one of my key priorities. Let me share with you some data. 1% of vaccines we are using in Africa, manufactured in Africa. 30% of medicines we are using in Africa, manufactured in Africa. Less than 5% of diagnostics we are using in Africa, manufactured in Africa. It means today Africa is not secure. It means today if we have another pandemic, we are exposed. This is why we are accelerating this agenda. Let me thank the partnership that we have with MasterCard Foundation. MasterCard Foundation provided $1.5 billion to Africa CDC. Part of this money, we are also pushing the agenda of local manufacturing. Yes, Pasil, you are right. We have a number of countries manufacturing vaccines. Let us just talk about vaccines. But what we saw in Africa CDC, some of these countries, they are manufacturing the same vaccine. We have a market of 1.4 billion people. We need to use, when we are talking about 1.4 billion, we are almost talking about the population of China. We want to use our market to ensure that manufacturers, they can produce and supply the market without any other issue. This is why we decided, and I discussed with our head of state, all of them, they are supporting that. We wanted to have a meeting in August, but due to some operational issues, we are having this meeting in September. This meeting will take place in Morocco. We'll have ministers of health, ministers of trade, ministers of finance, ministers of industries, and local manufacturers from Africa. All of them, plus some partners, will meet in Morocco in September. We are discussing who is doing what, where. It means who's manufacturing what and where, and how we can facilitate the decision. This is the first leg. The second leg, Africa CDC managed to have extensive discussions with Gavi the Global Alliance for Vaccine and Immunization in the world. For your information, Africa CDC attended the Gavi board meeting for the first time a few weeks ago. We managed to push the agenda of local manufacturing in Africa. Gavi, under a specific initiative for African manufacturers, they have now $1.1 billion dedicated only for African manufacturers, plus what we call the premium. What is premium? Premium is because we are new, our manufacturers are new, they start. The price from African manufacturers will not be the same like Indian manufacturers. To compensate, to ensure that we can still manufacturing product and sell that, we are requesting a 30%. It means if in Africa we produce a vaccine that can be $1.3, it means the $0.3 will be the premium that Gavi will pay, and we can consider that the price will be $1 because the 0.3 will be paid by Gavi. That can be competitive with Indian market. For that, we request a period of 7 to 10 years of maturity, because when you start with pharma companies, you need maturity for you to become competitive. You see, it's more technical, but I'm trying to simplify that. We are on top of that. It's our life we are talking about. It's our future we are talking about. We will never negotiate or compromise our future. I was clear with our colleagues from WHO, from UNICEF, from Gavi, and all of them. Africa CDC is leading this agenda in Africa. We are working together with them. We need to achieve that. What is our goal? By 23rd, at least 60% of vaccines used in Africa will be manufactured in Africa.
Thank you, Director General. Let us give our colleagues online a chance, and I will hand over to Benjamin.
Thank you, Win. Thank you, DG. La question suivante est posée par le Dr Michel Mouvoudi. Et la question est la suivante. Étant donné que les systèmes de santé des pays africains fonctionnent dans des contextes différents, comment Africa CDC pense-t-il prendre en compte cette variation contextuelle de chaque pays dans l'appui aux réponses pays face aux maladies? Merci. À vous, DG.
Dr Mouvoudi a totalement raison. On a différentes catégories de pays en Afrique. Nous avons des pays qu'on appelle à revenus élevés. On a des pays à revenus intermédiaires bas. On a des pays à revenus qu'on appelle low income countries, à revenus vraiment très bas. Je commence à perdre un peu de termes en français, pardon. Ça, c'est déjà sur le plan économique. Sur le plan sécuritaire, nous avons des pays qui font face à l'insécurité. On a des pays qui sont où la sécurité est très bonne. Nous avons un autre plan, des pays qui font face à des conditions climatiques extrêmes, des pays où le désert est en train d'avancer à grands pas. Mais on a des pays de forêts. Mais aussi, sur le plan programmatique, on a des pays qui ont des avancées sur le plan programmatique, sur le plan digital, sur le plan financement du secteur de la santé, sur le plan de la qualité des ressources humaines. Tout ça, c'est le contexte d'Afrique. Ce qui marche bien en Afrique du Sud n'est pas forcément ce qui va bien marcher au Niger ou au Mali. Notre rôle en tant qu'Africa CDC, c'est de tenir compte de tous cette diversité. En réalité, pour nous en Africa CDC, nous disons la diversité, c'est notre richesse. Comment nous pouvons tenir compte de toutes ces diversités pour orienter des pays avec des programmes qui sont taillés sur mesure pour eux. Un pays, comme je disais dans le cadre de l'investment case, si l'Afrique du Sud peut commencer par mettre 70% pour l'investment case, un autre pays, par respect que je ne citerai pas, peut commencer par 10% dans son investment case. Donc, nous sommes très flexibles. Mais au finish, nous disons ceci. La sécurité d'un pays, c'est aussi la sécurité de tout le monde. Et donc, nous devons nous arranger dans l'appui que nous donnons au pays, ensemble avec nos partenaires, que nous puissions assurer que ces pays soient suffisamment sécurisés pour sécuriser tous les continents. Merci.
Thank you, DG. I think I would have to ask you to truncate your answers to make them shorter, because we have a lot of questions coming online and we may not finish before 4 o'clock. All right, let's have questions from the room. Yes, please.
Good afternoon. Mwangi Maina from the Standard Media Kenya. DG, my question to you is, in recent years before you took over, we witnessed not a so good relationship between the Africa CDC and the World Health Organization. And this kind of friction, which manifested itself like a tough war between the Africa CDC and the WHO. You've now taken over the institution. What kind of a relationship have you been able to establish between the Africa CDC and the WHO, and what kind of institution to institution cooperation should we expect in coming days?
DG.
Oh, thank you very much, my brother. Let me first tell you quickly that the first person I called, or who called me, was the regional director WHO AFO, my sister, Dr. Moeti, when I was elected. Since then, every week we have a call. I believe that relationship at organizational level start with relationship at personal level also. We are leaders of these organizations. We are trying to harmonize everything. And you must know that WHO is member of our governing board, of our advisory and technical council. I also have very good relationship with my big brother. I have to call him my big brother, Dr. Tedros. You see, we have these personal relationships are helping us to see how to drive the agenda of organizations. Today, there is no issue between WHO and Africa CDC. We have our role. WHO has the role. Africa CDC has also its role given by our head of state in Africa. Based on that, we know our mandate. We are working together. This is why you see every time I'm talking about how we are working together, not only with WHO, but with UNICEF, with UNAIDS, with all other partners. I think no one can come today and say, if it was the case in the past, I don't know, because I don't have any evidence on that. But currently, I can tell you, there is no issue between WHO and Africa CDC.
Thank you very much. And I think that your response answers also the question that's coming online from Didier Mbai Kangudi, who was asking, are there any coordination mechanisms or collaboration frameworks to avoid duplication of efforts between the Africa CDC and other health organizations such as the WHO? So you've just explained that for us. Let's move on to, all right, the next one is anonymous. We cannot take questions from anonymous. So let's come back to the room and just check if there's anyone else with a question. All right, let me hand over to Benjamin for the next question. This is anonymous. Take this one.
La question suivante est de M. Aimé Mianga. Je suis Aimé Mianga. La RDC étant un véritable réservoir des épidémies en Afrique, je suggère à ce que l'équipe Africa CDC RDC soit élargie en ressources humaines en vue d'accompagner le ministère de la Santé publique, prévention et contrôle de l'infection à faire face au mal tentaculaire qui déchire le social du peuple congolais et d'Afrique en général. Quelle procédure Africa CDC applique pour qu'un personnel passe d'un membre non permanent à un personnel permanent?
DG.
Oh, merci à notre collègue qui a posé cette question. Nous avons des épidémies, je vous ai donné les épidémies que nous suivons dans plusieurs pays en Afrique. 22 pour 15 pour la rougeole, on a donné 22 pour 15 pour le choléra, 22 pour la rougeole et tant d'autres. Bien sûr, la RDC est parmi ces pays qui ont des épidémies en Afrique. Et comme tous les pays, moi en tant qu'Africa CDC, tous les pays sont importants pour moi, les 55 pays africains. Mais effectivement, quand nous catégorisons par rapport à ce qu'on appelle les disease burden, donc le poids de la maladie, nous arrivons à donner aussi priorité aux pays où ce poids de maladie ou des épidémies est important. Par rapport à ça, nous avons une équipe d'une dizaine de personnes en RDC pour répondre clairement à cette question. Et cette équipe est en train d'appuyer le ministère de la Santé. On est en train de voir comment bien organiser cela pour avancer. La question sur les staffs permanents et non permanents, on n'a pas ce concept à Africa CDC. On a le concept de ce qu'on appelle les staffs professionnels et les staffs d'appui qu'on appelle les general staff. Et les staffs professionnels, c'est des gens qui sont des experts dans les domaines et qui sont recrutés selon les différents grades. Mais ces gens peuvent devenir ce qu'on appelle les staffs réguliers si le financement vient directement de l'Union africaine ou non réguliers si le financement vient des partenaires. Mais tout le monde est sur le même pied d'égalité. Merci.
Thank you. The next question is coming from Rachel Abuja, who is a public health journalist with the news agency of Nigeria. One of the fallouts of the COVID-19 pandemic is the erosion of trust in governments, a situation that is now affecting health outcomes. This includes an increasing level of vaccine hesitancy, neglect for public health, and social measures, among others. The implications of this may continue to be seen for decades as the risks for infectious disease outbreaks and pandemics continue. All right, she goes on to say, mass media are a central authority in communicating health risk and information, yet they are often undermined or censored in African countries. They have the potential to influence the risk perception and behavior of the population, create risk awareness and understanding, and reduce social damage. Director General, how will you be proposing policy changes that protect the media's reporting of development issues, especially those related to disease outbreaks?
Thank you, my sister. And let me say that I had a nice meeting with your president today. I will visit Abuja very soon. Maybe we can have also opportunity to interact. You are totally right. One of the enablers of our program is how to strengthen the communication aspect. We are here with colleagues from media. Most of them are also following virtually. We need to strengthen our relationship. We need to provide information, appropriate information to media. I learned from my little experience that where you don't have information, you have rumor. And if you have rumor, it can destroy your program. We need to strengthen. I think regularly we need to have this kind of engagement with media. You didn't send me your questions. I'm responding openly and directly. It means feel free to ask all questions. Regarding vaccine hesitancy, I took time to see data. You'll see if that one was the case in some countries regarding COVID, but for other antigens, it was not the case. It means people, they still accept vaccines, but due to some rumors around the COVID vaccine, some of them, they were reluctant. This is why we said in our the way we are moving with our program, we are integrating the COVID vaccination into the routine system. That one will help our populations, our communities to see that Africa CDC is not there for COVID vaccine only. Africa CDC is there to support the whole vaccination program and the whole system. By also improving in our policies, the policy can be improved by ensuring that the dialogue between member states, media, Africa CDC and all partners will help us to know exactly what is the issue, how to answer to the issue. Then, one word to answer this question: communication.
Thank you, Excellency. Actually, I think that's a challenge to all of us in this room because that's really our job. So communication has been flagged as being key in terms of combating rumors. Let me hand over to Benjamin for the next question.
Merci, Win. La prochaine question, c'est de Bonheur Ndoko. À quand l'installation des bureaux pays dans 54 États membres? Je rappelle à Bonheur que c'est 55 États membres, pas 54. Merci. À vous, Monsieur DG.
Merci. Effectivement, en Afrique, il y a 55 pays reconnus officiellement. Et comme je disais, le directeur général d'Africa CDC n'a pas de pays. Il a un seul pays qui s'appelle l'Afrique. Donc, partout où il y a des êtres humains qui ont des problèmes de santé, Africa CDC est là en Afrique. Nous avons des points focaux dans presque tous ces pays, mais nous devons renforcer cette approche, nous devons bien les ficeler et nous devons nous assurer que les leaders de la santé et les communautés savent que Africa CDC est là. Donc c'est un processus que nous avons commencé avec toute l'équipe d'Africa CDC que je remercie ici pour leur soutien.
Merci. Any questions from the room? All right, so we're back to Benjamin.
Merci, Win. La prochaine question, c'est: vous avez parlé d'une indépendance dans la production, et la question vient de Roland Chitengue. Vous avez parlé d'une indépendance dans la production des médicaments. Qu'en est-il du développement des médicaments? Je veux parler des médicaments conçus par les Africains. Donc, en gros, des questions de recherche et développement. À vous, DG.
Merci à notre frère Roland pour la question. J'ai dit que 30% des médicaments que nous utilisons en Afrique viennent des Africains. Donc 70% vient de l'étranger. Ce n'est pas acceptable. Mais c'est quoi les médicaments? Les médicaments, c'est ce que nous prenons dans nos forêts. C'est ce que nous prenons dans nos sols et nos sous-sols. Et donc ça signifie, chacun sait ce qu'on appelle la médecine traditionnelle. Ça signifie qu'Africa CDC, nous avons une grande branche qui appuie ce qu'on appelle la recherche et le développement, et puis qui permet à ce que nos chercheurs et les gens qui utilisent les plantes puissent commencer à expérimenter cela, bien guidés, pour que cela puisse conduire à mettre ça sous la forme acceptable des médicaments avec des dosages appropriés, et pour que nous puissions commencer à utiliser. C'est comme ça que la Chine a fait des progrès. Nous allons faire ça aussi.
Thank you, Doctor. Let's go to Guy Alain Ramazani. He says, thank you, Doctor, for the presentation. What kind of challenges do you get when you are building the public health system in the countries with COVID-19?
all African countries were affected by COVID. And we had some countries seriously affected, others it was moderate, and we have also the third category where it was not too bad. It means when we are discussing the issue of health system strengthening, we are taking it into consideration that aspect. And as we said, we are supporting countries based on their context and their realities. We have so many challenges, starting from human resources, availability of quality and quantity human resources. We are talking about supply chain management. We are talking about information system. We are talking about financial mechanism. We are talking about coordination mechanism. Let me talk about coordination mechanism, the last one. Colleagues, out of 55 countries, we just have around 10 countries with National Public Health Institute functional. What is a National Public Health Institute? You know, in many countries, when they have outbreak, they put in place an ad hoc committee led by an expert. They will do that for Ebola, they will do that for COVID, they will do that for measles, and then at the end you have maybe 5-6 ad hoc committees. But if you have the National Public Health Institute, this is the house for a country to lead the preparedness and the response to outbreak. It means to respond to our colleague, we are saying we are tackling all of these challenges by putting in place mechanisms like the National Public Institute to manage all of these outbreaks.
Thank you. Over to Benjamin for the next one.
Merci, Win. La prochaine question, c'est celle de Wena Djebo, Dr Djebo, qui dit que l'intelligence artificielle offre des avantages sérieux en termes d'avancées médicales. Comment Africa CDC peut tirer profit de l'intelligence artificielle dans le domaine de la prévention des maladies infectieuses? À vous, DG.
Merci beaucoup. Intelligence artificielle, nous sommes tous, on voit comment on peut utiliser cela. Ça change le monde aujourd'hui. Et il y a quelques semaines, quand cela avait été annoncé, même on a vu des catastrophes dans les universités où les étudiants pouvaient avoir des questions venant de l'intelligence artificielle. Ça signifie que la santé peut bénéficier de ça. Il y a des questions qu'on peut poser, il y a les connaissances qu'on peut tirer de là. Nous devons utiliser toutes les technologies. J'ai déjà répondu à la question sur les technologies. Tout ce qui s'offre à nous, l'Afrique ne peut pas être en marge de ça. Nous avons créé un grand département dans la nouvelle structure. On aura quelqu'un à un niveau très élevé qui va diriger tout ce qui est nouvelles technologies, intelligence artificielle, pour voir comment Africa CDC va capturer tout cela pour nos programmes de santé.
Merci. Any questions from the floor? All right, we go back online and we have a question from Yauba Saidu. When we look at the health-related SDGs, we see that progress towards targets has stagnated and even is sliding backwards in many African countries. Is there anything that the Africa CDC can do to help accelerate progress in its member countries?
Thank you, Yauba. You are right. You know, let me give you another indicator. Before COVID, I won't name this country. We saw a country in Africa having around 1 to 2% of children zero dose. It means children who didn't get any vaccine. From 2019, 2020, 2021, with COVID, zero dose in this country jumped from 1 to 11%. When you have 11% of children not vaccinated, it means you are opening the door to all outbreaks. For us, if we continue like that, we are not moving with the agenda of SDG, but we are decreasing. And it means we are opening, we are putting our health system at risk. What we are doing is to conduct a strong situation analysis, country per country, to know how the system is reflected in a specific country, what can be the contextualized program that we can provide to this country. I attended a meeting in DRC a few weeks ago with President Tshisekedi about what they call the Plan Machako, how to vaccinate a number of children. And it was so nice to see how a country can come with a strong leadership and providing funding for the immunization system. This is why Africa City committed even to provide additional funding to that. I think this is exactly what we want. First, we need the ownership and the leadership of the government. We need a strong situation analysis to know what is working, what is not working, and third, to find appropriate solution based on the situation analysis.
Thank you very much, Doctor. Now we go on to someone who's asking about Ebola. And it is K Cross, and they're saying, what are the specific strategies in place to counter Ebola in Central Africa?
Ebola was so bad around 2015, 2016, when West Africa was affected. But we know also we had a number of cases of Ebola in DRC, in Uganda, and other countries. In the beginning, we didn't know that we had any countermeasure against Ebola. Today, I was talking with Professor Muyembe. He managed to put in place the countermeasures. It means we need to start when we have Ebola. We have also what we call the vaccination when you have the outbreak. We have vaccine today against Ebola. We have some medicines that we can provide to help people to prevent other infections. But the most important one is communication, information that we are providing to community, how to prevent the spread of this outbreak. If we have in place a strong communication system, if we have in place a strong surveillance system, the surveillance system will help us to detect the first case and to follow the contact. If we have in place a stock of vaccines and other medicines, and we are supporting with the communication component, these are key strategies that can help us to tackle Ebola outbreak in Central Africa.
Thank you. Back to Benjamin.
Merci, Wim. La question suivante est celle de Jean-Pierre Mourama qui dit quel rôle Africa CDC joue-t-il dans la gestion des crises de santé liées aux conflits politiques en Afrique et comment travaillez-vous en collaboration avec les acteurs politiques et les organismes internationaux pour garantir l'accès aux soins de santé dans ces contextes complexes? Merci, à vous déjà.
Merci à Jean-Pierre. L'épidémie ne choisit pas des frontières. La maladie n'a pas une frontière bien délimitée. Africa CDC, notre rôle, c'est de gérer les maladies et les épidémies en Afrique. Quand je parle, j'ai un cœur lourd par rapport à la situation du Soudan, où nos populations sont en train de mourir et nous ne pouvons pas leur donner toute l'aide. Et il y a des épidémies. Mon équipe m'a donné un rapport sur les épidémies qui viennent. Rougeole, polio et autres. Ce que nous faisons à Africa CDC, nous parlons avec tous les leaders. Aujourd'hui, j'ai eu l'occasion de voir, ils sont encore dans la salle, je vais les voir pour les lunchs, quelques 6 ou 7 chefs d'État. J'ai été avec une cinquantaine de ministres des Affaires étrangères et un bon nombre de ministres de la Santé de ces différents pays. Je m'assois avec des ministres des deux pays qui sont parfois en conflit. Je les mets ensemble pour discuter les problèmes de santé publique. C'est ça mon rôle comme directeur général. C'est de promouvoir ce qu'on appelle les Global F diplomatie. Donc, la diplomatie de la santé publique. Deux pays peuvent être en conflit. Nous allons leur montrer l'intérêt de travailler ensemble par rapport aux problèmes de santé. Sinon, ces deux pays vont disparaître. Donc ça, c'est mon rôle et je le fais. Si les gens suivent mes voyages, ils voient que mon équipe et moi-même, nous partons partout où les problèmes se posent. On essaie de mettre ensemble des équipes et dans notre rôle, nous coordonnons la réponse au niveau du continent et au niveau des régions. Merci.
Thank you, Director General. The next question is a bit difficult to understand, but I'm going to give it to you anyway. It's coming from Jacques Miango. And Jacques says, bilateral relationship, win-win, is true only when you can bring some things to the table. What is Africa CDC bringing to the table to achieve its goals? Now, DG, I know you've spoken a lot about what the Africa CDC is doing, things that are funded by Africa, the interventions, the issues that you spoke about, local manufacturing, all these things are African-owned. So this question says, what is the Africa CDC bringing to the table? So I don't know if you have anything extra to try and show that the Africa CDC is indeed doing something as Africa CDC.
Thank you very much to our colleague. He's absolutely right. I have to say to head of state when I was candidate, I had to say to my colleagues when I was elected, that you cannot go to partners, especially external partners, by saying, my hands are free, just give me something. Our leaders now in Africa are talking about respect. We need to be respected. This is why Africa CDC, we submitted, and it's important for colleagues to know that, we submitted what we call the Financial Sustainability Plan of Africa CDC. Under this Financial Sustainability Plan, we have clear mechanism to create funding for Africa CDC. This funding that we'll create, like for those who had the opportunity to read my manifesto, we are talking about the airline tax. This airline tax will give to Africa CDC per year around $300 million, plus contribution from member states, plus other type of contributions. We'll have this money. Then when we go to our external partners, we say, we have a program of X billion dollars. I don't call it our contribution because it's our responsibility. Our money is this $500 million or $400 million. We do what we call the replenishment meeting. Then they will provide funding based on our fundraising plan that is coming from our strategic plan, and also based on the funding that we have available. The same will apply to our countries. We want our countries, this is why I discussed with colleagues about the investment case. We need to start to invest in our public health sector.
Thank you so much, Director General. Unfortunately, I don't think that we can get through all the questions that are coming through. So this has really been very well subscribed, a lot of questions. But what I will do is refer colleagues who still have questions to please forward them to Africa CDC. If you go online and you look for their website, www.africacdc.org, you will find their contact details. So please do send in your questions there for further assistance. But in the meantime, let me announce the next press conference, which is coming up very soon. It is the briefing of the Commissioner of Political Affairs, Peace and Security, His Excellency Ambassador Bankole Adioye. And he's going to be touching on implementation of the Interregional Knowledge Exchange, the AU-UNDP Africa Facility to support inclusive transitions, and also on political and peace and security issues on the continent. So we invite you to join us for that briefing, which will be starting as soon as the Commissioner is available. We will obviously be informing you on the exact times, but those who are here, you may want to just hang around for a bit so that we confirm exactly what time the Commissioner will be in. But for now, let me thank very much Dr. Jean Kaseya, who is the Director General of the Africa Centers for Disease Control. Let me also thank all the colleagues who are here from the media and from the communications sector, colleagues who I see many faces from the Africa CDC itself, and also the Deputy Director of the Africa CDC is actually here with us, so thank you very much for coming. And then lastly but not least, let me give a very big thank you to colleagues from the interpretation services who have really enabled us to communicate effectively as we switched from English to French and from French into English. So thank you very much for having been with us. Bye-bye for now.